So we mentioned previously that different internal organs can be innervated sympathetically or parasympathetically. And in one of the lectures focusing in on those two divisions of the ANS, we showed all of the different organs that can be innervated in this way. So, for example, the lungs can be innervated sympathetically and parasympathetically. The heart, the eye, the GI tract, and so on. And at that time, what we didn't mention was that certain innervations are leaning in one direction, meaning that some of the effector tissues, which are innervated by the autonomic nervous system, will be primarily one type of innervation, rather than 50% sympathetic and 50% parasympathetic. We have what we call the predominant tone, or the predominant innervation, where on this table we see arterioles and veins are predominantly innervated sympathetically. And so that will, when stimulated, when those adrenergic receptors are stimulated, will cause vasoconstriction. So if you were to block the signal higher up within the ganglion, right? If you were to block that second fiber from being able to depolarize and release norepinephrine, and if the predominant tone is sympathetic, normally favoring vasoconstriction, what would you see? And that's described in the third column, the effect of ganglionic block. And so you would see vasodilation if you use a ganglionic blocker. In the heart, excuse me, the heart is primarily innervated parasympathetically, although it doesn't mean it's exclusively innervated parasympathetically. We know that the heart has adrenergic innervation as well. And so what will be the effect of ganglionic blockade on the heart? What will be the effect of ganglionic blockade on the iris or the ciliary muscle or the GI tract, and so on? And so this leads us to the next type of anticholinergic drug, and this is the ganglionic blocker. Remember, the ganglionic blocker is going to be inhibiting the nicotinic receptor in the ganglion, which is also known as the neuronal type of nicotinic receptor. And so this slide has a depiction of some compounds which exhibit an ability to block the neuronal type of nicotinic receptor in the ganglion. You see things here like hexamethonium, tetraethylammonium, and mecamylamine. Now, of those three, mecamylamine is really the only one that is used clinically. Hexamethonium, tetraethylammonium are not encountered clinically, more encountered in the research setting. And I want to talk a little bit now about some of the ganglion. Now again, think about where the ganglion, or where the ganglia, plural, are. Okay, they are the central hub that connects the first fiber to the second in both the sympathetic, parasympathetic, and modified sympathetic ganglia. Remember that first fiber coming out of the CNS releases acetylcholine, depicted here in the ganglia as a white circle. And that acetylcholine will bind to nicotinic receptors. If those nicotinic receptors are activated in the adrenal medulla, you'll see release of epinephrine, norepinephrine. If those nicotinic receptors are activated in the ganglia that then innervate an effector tissue and release norepinephrine, then you'll see an adrenergic response. That second chemical that's released is acetylcholine. You'll see a muscarinic response. And that's all of what we've talked about thus far, right? That left portion of this figure. The right portion of the figure shows what happens with the somatic nervous system. The first fiber coming out of the CNS, and the only fiber, really, which synapses on the neuromuscular junction. Releasing acetylcholine, binding to the nicotinic receptor of the M class. So the NM receptor. And so the ganglionic work by blocking that second fiber right? By blocking the nicotinic receptor, they're really shutting off the second fiber. So the release of epinephrine goes down, the release of norepinephrine goes down, the release of acetylcholine goes down in the affected tissues. What would that do, for example, to blood pressure if there's less epinephrine being released, if there's less norepinephrine being released? Will the heart beat as hard and strong as it otherwise could? No. Will the blood vessels constrict as they usually would in response to, for example, norepinephrine? No. And so blood pressure can fall. And in fact, the ganglionic blockers work in the ganglia, and their main clinical use is for the emergency lowering of blood pressure. And so the first of these ganglionic blockers that I'll mention is nicotine. And nicotine, as we already spoke about in class, can have a different kind of pharmacology, which is dependent on the dose. Okay, in the presence of high dose and continuous stimulation, the nicotine can depolarize the receptor. But in the presence of continued agonists, that receptor will then become blocked. That process is called depolarizing blockade. And if you look at the last bullet, what it tells you is that at a higher dose where you have depolarizing blockade, the blood pressure falls because the ganglion is blocked. That nicotinic neuronal receptor is blocked through desensitization. And the activity of the ganglion is turned off. Now, nicotine is not commonly used as a ganglionic blocker, but it has the ability to block the ganglia at high dose, which is used in the clinic to block the nicotinic neuronal receptor in the ganglia. It's called trimethophan, and there's another one as well, which we'll discuss next. But in the case of trimethophan, if you look at its structure there in the lower left panel, you'll see there's a full positive charge on the sulfur. And so this drug is going to be given through an intravenous infusion because the drug as is carries the full positive charge, which makes it difficult to absorb. Trimethophan is given intravenously, and it is used for the emergency lowering of blood pressure. So somebody comes into the emergency room and their blood pressure is, 205 over 155, right? Much higher than it should be. And the physician decides that we have to lower that blood pressure, and we'll deal with other types of antihypertensives later. So we have trimethophan as a ganglionic blocker, and we have mecamylamine. Now, mecamylamine is also a competitive inhibitor of the nicotinic neuronal receptor in the ganglia, but this is a drug that can be given orally. If you look at its structure, you see there's no full positive charge on it. The drug has therefore an ability to be absorbed. Its duration of action is about 10 hours, and of course it can be given orally. So really, when it comes to the ganglionic blockers, for the most part, these are drugs which are either experimentally of interest to the pharmacologist or has a very narrow usage in practice, which would be to block ganglion or block ganglia, and in so doing reduce blood pressure by really turning off the sympathetic stimulation that's going to the heart. So again, please don't fall into the idea that there is no parasympathetic innervation of the heart, because we know that's false. It's just that most of the innervation, or the majority of the innervation, is sympathetic. So if you block that, you decrease the body's signaling of epinephrine and norepinephrine and alleviate blood pressure. And the approach there is to get the blood pressure down, and then, once the patient is stable, to put them on more traditional antihypertensive compounds. If you look over to the right of this figure, you'll see an arrow pointing to the muscle type of nicotinic receptor, the NM. And now we're going to spend a few minutes in the somatic nervous system. Okay, most of what we've talked about in chapters 6, 7, and 8 have dealt with the autonomic nervous system. And in fact, chapters 9 and 10 will also focus there. So this is our little adventure into the somatic nervous system. And that red arrow shows that there are drugs which are known to block the muscle type of nicotinic receptor. And in fact, they're categorized pharmacologically into two groups. There are the non-depolarizing nicotinic muscle type blockers, and then there are the depolarizing nicotinic muscle type blockers. And sometimes these are called skeletal muscle blockers or skeletal muscle relaxants. And they can be categorized as either non-depolarizing or... Let's first talk about the non-depolarizing skeletal muscle blockers. And we'll use an example of a drug called tubocurarine. Now, tubocurarine is an active ingredient in a mixture called curare. Curare is a mixture that was developed by native hunters in the Amazon in South America. And these hunters used curare in their hunting. They would dip the arrow tips into curare and then shoot their prey. And what the curare would do is it would paralyze the animal. The animal could then not escape, and the hunter would be able to approach and obtain the animal for the tribe or for the family, so that there would be, some kind of meat to eat. And so this curare was a mixture that was intriguing to the pharmacologists of the late 1800s, and they actually identified the active ingredient as tubocurarine. And so what we now know is that tubocurarine blocks the nicotinic receptor in the skeletal muscle, and it inhibits the contraction of that skeletal muscle. It does so, it blocks that muscle in a competitive antagonist manner. Okay, tubocurarine is a non-depolarizing blocker or a non-depolarizing competitive antagonist of the muscle type of nicotinic receptor. Now, tubocurarine's pharmacologic action can be overcome by increasing the concentration of acetylcholine in the synapse. How can you do that? By using, for example, a cholinesterase inhibitor, something such as edrophonium or neostigmine, and that will do the job of increasing acetylcholine. A little bit about tubocurarine from a pharmacokinetic stance. The drug must be given intravenously, or must be administered intravenously because of poor absorption. The drug penetrates cellular membranes very poorly, and it does not cross the blood-brain barrier. Of interest is that it is not metabolized. It is one of the rare drugs which gets excreted into the urine unchanged. And the way that it really stops working, or the way that its effect is terminated, is by a redistribution out of the skeletal muscle to the kidney, where it gets dumped into the urine. In terms of adverse effects, tubocurarine, though most active at the muscle type of nicotinic receptor, has been found to be able to inhibit the neuronal type of nicotinic receptor in the ganglia. And so some patients who have taken this compound as a skeletal muscle relaxant have shown a lowering of the blood pressure. Tubocurarine is predominantly considered a muscle nicotinic receptor antagonist, but it does have some ability or some affinity for the neuronal type as well. I won't really focus on the drug interactions of tubocurarine. I'm more just interested in you knowing it as an example of a non-depolarizing skeletal muscle blocker, skeletal muscle relaxant. Now I'd like to turn our attention to an example of a depolarizing neuromuscular blocker, and that's the drug succinylcholine. Now, succinylcholine is a depolarizing neuromuscular blocking agent. It attaches to the nicotinic receptor and acts like acetylcholine and actually depolarizes the skeletal muscle cell. Just ignore that phase 1 in parentheses. We're not talking about metabolism right now, and I don't want to confuse you. So just remember that the succinylcholine binds and depolarizes that muscle type of nicotinic receptor. But that receptor can go through desensitization. And so prolonged binding of the depolarizing agent results in the receptor being incapable of transmitting any further impulse. And so the receptor is now blocked. First depolarized, and then unable to respond. Okay, and some people call that phase 2 of the desensitization. We don't have to focus on the phases of desensitization here, but rather just understand that a depolarizing agent is one that first depolarizes the skeletal muscle cell and then paralyzes it because of the nicotinic muscle type receptor becoming desensitized through the process of depolarizing block or depolarizing blockade. So, succinylcholine as a drug. It's an analog of acetylcholine. It generally has a short duration of action because of esterases in the blood or in the plasma. Succinylcholine is not able to produce ganglionic block. And therapeutically speaking, what is it used for? It's useful when doing brief surgical procedures where muscle relaxation is needed. So for example, something like a rapid endotracheal intubing, putting a tube through the trachea into the lungs, which is required during the induction of anesthesia for people who are going under general anesthesia. So succinylcholine has a very narrow utility, but what it does is it causes paralysis of skeletal muscle that would otherwise, for example, try to prevent the intubation from occurring. The chief adverse effects to be concerned about in a patient on succinylcholine are the rare but serious adverse effects of malignant hyperthermia and apnea. Now, malignant hyperthermia can be the result of skeletal muscle becoming hyperstimulated and actually increasing the body temperature all throughout regions where there's skeletal muscle. This has been found to occur in some patients when given succinylcholine and the anesthetic halothane. Okay, so it's a rare but serious adverse effect. It's been mostly observed when halothane was the anesthetic, and it's something that we need to be aware of because it can be life-threatening. Okay, some patients that are given succinylcholine can also develop apnea, and these tend to be patients that have a genetic deficiency of cholinesterase, where the succinylcholine lasts longer than it otherwise would in a patient with functional cholinesterase. So remember, succinylcholine is a depolarizing neuromuscular blocking agent, and it can cause the rare but serious adverse effect of malignant hyperthermia. This picture is an example of the endotracheal intubation that we mentioned a few minutes ago. In the physician's left hand is an instrument called a laryngeoscope, And this laryngoscope is basically used to hold down the tongue so that the tube can then be inserted into the trachea. This is done when a patient comes into the emergency room in an unconscious state and when their reflexes are depressed. And the process of endotracheal intubation is made easier by the use of a drug like succinylcholine. And so now we've gotten up to a potential scenario where a 50-year-old farm worker is brought to the emergency room. He was found confused in the orchard and since then has lost consciousness. His heart rate is 45. His blood pressure is 80 over 40 millimeters of mercury. He is sweating and salivating profusely. Which of the following treatments would you choose? Okay, so what are the key things in the question? Because you might see questions like this on the final exam. What are things you need to think about here? Well, the patient was found confused. So potentially we've got some kind of central effect here. And then he lost consciousness. His heart rate at 45, is that high or low? That's considered low. And his blood pressure is 80 over 40 millimeters of mercury. Is that considered high or low? That's considered low. So he's got a low heart rate. He's got low blood pressure. He's sweating and he's salivating profusely. Okay, that sounds like maybe muscarinic excess. And the heart rate being down, the heart's beating slower than usual. Okay, that sounds like muscarinic excess. So what kind of drug would we give? Would we give edrophonium, which would increase acetylcholine in the cleft? Or physostigmine, which would increase acetylcholine in the cleft? Or norepinephrine? What would norepinephrine do to the heart rate? Alright, it would increase the heart rate. What would it do to the blood pressure? It would bring the blood pressure up. So is that the drug you would use? What about the salivation? What about the sweating? Okay, so it's maybe on the short list, but I'd look further. Trimethophan? No way. I don't want to lower the blood pressure anymore. And atropine. What's atropine doing as a drug? It's blocking the effects of acetylcholine. So in fact, atropine sounds like the better drug to use of the choices because you can block the excess muscarinic stimulation. Right? What else might you use in this case if you knew that this is muscarinic excess due to, for example, overexposure to an organophosphate? Atropine and 2-PAM, pralidoxine. Okay, so when you get presented with a question like this, look to see what some of the clues are in terms of the answer. You hopefully definitely knew it wasn't edrophonium or physostigmine or trimethophan. And if you narrowed it down to atropine and norepinephrine might get the heart rate up and the blood pressure up, but it's not going to do anything to the sweating or salivating. And norepinephrine can't cross the blood-brain barrier, so it's not going to have any effects on the central aspects of this problem with the confusion. Okay, while atropine will block muscarinic activity throughout. So that brings us to another issue within Chapter 8, or another perhaps disease state, I should say, more appropriately, that can be treated by using inhibitors of the muscarinic receptors. And although there are many drugs that can be used to treat urinary incontinence, if you look at this slide, in the middle of the slide, you see something called bladder relaxants. And you'll learn about these other drugs, the alpha agonists, or the tricyclic antidepressants, or the estrogens. You'll learn about them again when you get to genitourinary pharmacology in D&D. But today I want to just briefly speak about a few of the bladder relaxants that can be used to relieve urinary incontinence that work by blocking muscarinic receptors. And we've already talked about one on the board, hyoscyamine, and I want to mention some of the others, such as oxybutynin, darafenacin, trospium. And so on this slide, what you'll see is an axon terminus above the synaptic cleft, and below the synaptic cleft, or on the other side of the synaptic cleft, you see a cell membrane that contains M3 receptor. And so in the typical situation in the bladder, we see that acetylcholine gets released from the presynaptic axon terminus, and it can bind to postsynaptic effector cell through the action at M3, and will therefore stimulate that receptor, and that will result in contraction of the bladder and release of urine. But if you look above, if you look at the presynaptic axon terminus, you see that there are other types of receptors there, right? Presynaptic receptors, M1s, M2s, M4s. And it's believed that the presynaptic M2 and M4 receptors inhibit the release of acetylcholine, while a presynaptic M1 receptor would release even more acetylcholine if activated. Remember we talked about presynaptic receptors, and we said we can have inhibitory receptors or stimulatory receptors with respect to the release of transmitter. So while activation of the M2 and the M4 on the presynaptic axon terminus would inhibit release of acetylcholine, right? So there's enough in the cleft, don't release any more. Binding the presynaptic M1 receptors would actually cause more acetylcholine to be dumped into the cleft. And so what we see here in the urinary bladder, for example, is acetylcholine will cause contraction of the bladder through activation of M3 receptor. And so if the problem is urinary incontinence and there's too much activation of the M3 receptor on the surface of the cells in the urinary bladder, then one approach, as you can see, might be to use a drug like atropine to inhibit that receptor from being activated. And so the drug that I'd like to mention in this capacity in a little more detail is oxybutynin. And oxybutynin is a antagonist of the M1 and M3 receptors. So the M1 receptor would be presynaptic, the M3 would be postsynaptic. What would happen if you block the M3 postsynaptic receptor? Does the bladder contract like it otherwise would? No. In addition to its inhibition of the M1 and the M3 receptor, oxybutynin also has the ability to antagonize calcium through a local anesthetic action. And that's been established in vitro. And so just in general terms, oxybutynin, in addition to its anti-muscarinic effect on smooth muscle, seems to have the ability to relax smooth muscle in a mechanism that blocks calcium from entering. So oxybutynin is going to be considered a drug that can be used in the treatment of overactive bladder, trying to promote urinary retention. And so on this table, you'll see OAB, overactive bladder. You'll see it in some of the columns. You'll see a discussion of some other drugs. But here I'm just asking you to concentrate on oxybutynin. And if you now look at this slide, and you look at oxybutynin, I've kind of circled some of the relevant pharmacology concerning oxybutynin in a blue circle, or in a purple circle, like a dark blue. And what I was trying to show you by circling that was that oxybutynin exists in different formulations. We have what are called immediate release tablets, which need to be taken several times a day. We have immediate release syrups, which need to be taken 2 to 4 times a day. We have an extended release tablet, which can be taken once daily. We have a transdermal patch formulation that allows the patient to just change patches every 3 to 4 days. Which of these formulations is probably the easiest to use in little children who have trouble controlling their bladder? The immediate release tablet, where they're going to have to take 2 to 4 pills a day, or the transdermal patch? Obviously the patch is much more convenient. If you look over here at the cost, and now this is a little outdated, a couple of years old, this study, but the patch is more expensive than the immediate release tablet. And so which of the formulations the patient uses might actually be influenced by financial options. But in terms of pharmacodynamics, we know oxybutynin blocks the receptor on the bladder that's needed to contract it. And so what I'd like you to think about with respect to this drug is the different formulations. You have tablets and syrups, which are immediate release. You have tablets, which are extended release. You have patches, which are even longer acting. And in terms of metabolism, we see that the major enzyme that metabolizes oxybutynin is cytochrome P453A4. So, is it possible to get a drug-food interaction with a patient who consumes lots of grapefruit juice and takes oxybutynin? It's possible. And then what would happen if that patient consumes lots of grapefruit juice and oxybutynin? The levels of oxybutynin would be higher or lower in the blood than they otherwise would be. Right? They'd be higher. Right? And so you might see some systemic effects that go beyond the bladder. Dry mouth, dry eye, tachycardia, and so on. One last column on that table, and again I've just focused on the blue circled properties of the table, is the drug uroselective? Meaning, is it selective for stimulating, well, for inhibiting, I should really say, the muscarinic receptor on the bladder, or can it inhibit muscarinic receptors in other places too? And the answer is, it's not uroselective. Oxybutynin will inhibit M3 receptors wherever it can. But in the treatment of overactive bladder, the ones we hope to block are those in the urinary bladder. Now, on this slide, you'll see that I circled a region on the upper right corner that's looking at another drug used in the treatment of overactive bladder called solifenacin. And I'm not really here to focus on solifenacin right now, but just if you look around and you look at its adverse effects, many of them are what you would expect for any old anti-muscarinic. Dry mouth, constipation, blurry vision. The graph on the lower left we won't focus on in intro. Okay, much of the data here I won't discuss with respect to other drugs used in the treatment of overactive bladder, where I'd like you to know that darafenacin and solifenacin and tolterodine are other options for the treatment. Sure. Are we going to talk specifics now in intro? No. I think we'll keep it just to oxybutynin. And again, if you look in the upper left table, you see that oxybutynin is a drug that's very poorly bioavailable, yet it's often given orally. And so what that tells you is the amount that gets out of the liver and goes systemic is still enough to have efficacy. So oxybutynin, compared to some of the other options, things such as tolterodine and solifenacin in particular, has a very low bioavailability, but that's okay because what comes through the liver is still enough to have. And so in the treatment of overactive bladder, having difficulty controlling urination, you'll see options such as oxybutynin or tolterodine or the phenacins, such as darafenacin, solifenacin, or trospium. In terms of adverse effects, down there in red, and there's actually a typo, oxybutynin should be oxybutynin instead of TI, should be TY. And what are the kinds of adverse effects? Again, the ones typical of antimuscarinics: blurry vision, impaired gut motility, constipation, dry mouth, dry throat, dry eye can occur. Right, so this is the panel of things you'd see with an antimuscarinic. Now, a few things to consider, a few contraindications or precautions with oxybutynin. This class of drug, the anticholinergic, may precipitate urinary retention in patients who have a pre-existing urinary tract obstruction or prostatic hypertrophy. So avoid using this drug if urinary retention is present. patient has difficulty expelling their urine, that's not what you want to do. But if they're overactive, and maybe they're bedwetting, or maybe they had an accident, or maybe they're a senior who's lost bladder control, then we can talk about a drug like oxybutynin. The extended release dosage forms of oxybutynin, as you've seen, there are some different dosage forms. Is not recommended in patients with renal impairment because of the extra stress that gets put on the kidney with the extended release. And important also that oxybutynin can increase intraocular pressure in patients with narrow or closed-angle glaucoma, and should be avoided in patients that have uncontrolled narrow-angle glaucoma. So closed-angle, narrow-angle, those are synonyms, and oxybutynin is a drug that should be avoided in these instances. Okay, so that brings us up to the end of the homework lecture. Basically, to provide a summary, we discussed ganglionic blockers, we discussed skeletal muscle blockers, and then we discussed the disease state of overactive bladder or urinary incontinence. And we listed several drugs in this class, but mostly focused in on oxybutynin and its pharmacology, its adverse effects, contraindications to keep in mind. And so with that, when we meet again in our next class, we will begin Chapter 9, the topic of which is adrenergic agonists. Remember that that's coming. Make sure you go to your blogs and make sure you're keeping up with your homework questions so that you will be able to process the information in a way that helps you and gives you enough time to do well on the final. And so with that, I'll say thank you for your attention, and I look forward to seeing you again in class where we will start our discussion of Chapter 9.